In this Medicoapps Masterclass, we are going to learn about peptic ulcer disease. Now, when we talk about peptic ulcer disease, primarily we are going to talk about gastritis, type A and type B gastritis. Then we are going to look at the manifestation of that gastritis in terms of gastric ulcer, both gastric as well as duodenal ulcers, their presentation and their complication and management. So this is how we are going to cover. So let's start our discussion with type A gastritis. Now, let me put it first that type B gastritis is more common than type A gastritis. So let's first do away with type A gastritis. Now, type A gastritis, if you remember this A, all the manifestations of type A gastritis can be very easily identified. For example, it is an autoimmune disorder. Okay, so autoimmune disorder, and what are these antibodies directed against? They are directed against the parietal cells. So anti-parietal antibodies are formed in type A gastritis. So what will happen when anti-parietal antibodies, parietal cell antibodies are formed? There will be a destruction of parietal cells, and what will happen because of destruction of parietal cells? These parietal cells are very important for your formation of HCl. So this will lead to decrease in the formation of HCl, also called as achlorohydria. Now, this achlorohydria will lead to the formation of gastric ulcer. Many students get confused that even though, sir, HCl is decreasing, why there is a formation of gastric ulcer? Remember, stomach has very good defense mechanism against HCl. A lot of HCl is produced, and stomach has various defense mechanism against that HCl which is produced. Now, in this type A gastritis, not only the parietal cells are destroyed because of these antibodies, but a lot of these inherent defense mechanism of the stomach, the inherent defense mechanism of the stomach, which protects the stomach lining from this acid produced by the stomach, that also is done away with. And because of the decrease in the defense mechanism of the stomach, okay, even though the amount of acid production is decreased, but still it will cause gastric ulcer. I hope you are clear about this point. The defense mechanism of the stomach, the various defense mechanism of the stomach, which protects the stomach mucosa from the acid which is produced inside the stomach, that also is impaired in this, and that's why even though there is an achlorohydria, there will be gastric ulcer. Also, another very important function of parietal cells we all know is the formation of intrinsic factor. And obviously, if the intrinsic factor production goes down, there will be B12 deficiency, which can present as macrocytic anemia. Now, because there is ulcer, remember it is pre-malignant. Again, a very, very favorite question. All gastric ulcers are pre-malignant. Remember this. So, because there is an ulcer formation, this type A gastritis will come under pre-malignant conditions. So, these are very, very important points. These are the only 4 or 5 points which you have to remember about type A gastritis. Let's move to the more common cause of gastric ulcer, or gastritis, that is type B gastritis. Type B gastritis we know is because of H. pylori infection. This is the most common cause of type B gastritis. Now, there are certain important points about H. pylori which have been very frequently asked in the examination. For example, it's a gram-negative extracellular cocobacilli. Okay, it's a gram-negative extracellular cocobacilli. It is microaerophilic and non-spore forming. So, what does this non-spore forming, is important, because if any bacteria is non-spore forming, eradication with treatment is possible. Okay, eradication with treatment is possible. Remember this very important fact. So it's a gram-negative extracellular. Why? We have seen in tropical sprue what is happening. The bacteria is intracellular, but here this H. pylori is extracellular. What is the mode of transmission of this H. pylori? It is fecal-oral. Okay, again a very favorite question, and it produces a specific enzyme called as urease. And what is the function of this urease? It will split urea into ammonia. Okay, so this is few important points about H. pylori. What is the mechanism by which it causes gastritis or gastric ulcer? Basically, what happens when ammonia is formed because of this urease enzyme? We know that ammonia is alkaline. Okay, and this alkaline ammonia will irritate both your G cells as well as parietal cells. Okay, both G cells and parietal cells are irritated, and this will lead to the excess production of the acid. So hyperchlorhydria is there, and this will obviously lead to the formation of ulcer. Now remember, here in type B gastritis, typically duodenal ulcers are relatively more common as compared to gastric ulcers. Why? Because even though the acid production is increased, but the stomach has inherent defense mechanism against this excess acid, so it is relatively able to withstand the excess acid. Whereas the duodenum does not have much of that inherent, defense mechanism against the acid. And so when the amount of acid production increases, it will be the duodenal ulcers which will be formed in such cases. Now remember one important point I have told you. In type A, there is a decreased production of hydrochloric acid. In type B, there is an increased production of hydrochloric acid. But remember, in both these cases, there will be increased production of gastrin. Why? Here there is a direct irritation of G cells, so gastrin production is increased. Here, what happens when the HCl is decreased? There is an achlorohydria that will lead to further increase in the gastrin. So in both type A and type B, even though the HCl level is increasing and decreasing, but the gastrin level will increase in both these conditions. So this again is a very, very important point. Now, having understood the pathogenesis, so what will we do to diagnose it? One of the easiest tests is the breath urea test. Again, remember, it's a screening test. It is a test for eradication when you have given a treatment to a patient, and then if you want to see if the H. pylori is eradicated, even then you can do this breath urea test. It's a non-invasive test. It's a very simple test. Here what happens is you are asked to exhale in a balloon like bag, and then in that bag the amount of carbon dioxide you exhale is measured, and then what you are done is you are given a lemon flavored solution. Basically this solution has urea, and because this H. pylori bacteria, what it will do is it will produce that urease, and the urea which you have just drank, it will split it into carbon dioxide and ammonia. Okay, and that carbon dioxide, again, when you are after drinking that fluid, you are asked to again exhale in the bag, and then the amount of carbon dioxide you have exhaled is measured. So earlier without ammonia, without urea, and then after urea, and if there is an increased amount of urea, carbon dioxide after urea, taking of urea, then that comes positive. So this is a very, very important test, very easy test to do, and remember it has almost 95% accuracy when it comes to being used as a screening test. The next is obviously a urease test. It's an invasive test. Flow test is the commercial name for this particular test, and typically when you are doing an endoscopy, okay, to look for the ulcers, then what you do is you take a biopsy, you do this wall scraping, and then you can do this urease test in those wall scraping. Okay, and remember this is the investigation of choice. So if investigation of choice is asked, it will be endoscopy along with biopsy or scraping urease test. But if they ask for a screening test or test for eradication, always go for breath urea test. Again, we can do a biopsy. We can stain it. The stain typically used is Warthin starry stain, and here you get is a golden stain, and black these black extracellular bacilli, cocobacilli is what you are going to see, H. pylori. So these are the three important investigations. Once again, I will tell you, if they ask about the screening test, it will always be breath urea test because it is non-invasive. If they ask you for investigation of choice, then you will always say endoscopy along with biopsy, and stain is very rarely done because you can do an urease test on the biopsy. So having completed that, this increase in the acid, the gastritis, can cause both gastric ulcer as well as duodenal ulcer. Let's quickly look at what will be the differences between a gastric ulcer and a duodenal ulcer. Now remember, gastric ulcer sits in the stomach. So what is happening, the moment you eat a food, then the pain will happen. Okay, but duodenal ulcer sits in the duodenum. Okay, first part of the duodenum, generally maximum up to the second part of the duodenum. So what happens when you eat food, the food is in the stomach, till then there will be no pain happening. The moment, what will happen is, the moment you have the gastric emptying happens, which generally happens around 2 hours, 1.5 hours after you have taken a meal. So once the gastric emptying happens and the stomach content comes in the duodenum, then you are having a pain. So this is the major difference in clinical presentation. A gastric ulcer patient, the moment he will eat, he will have pain, and a duodenal ulcer patient, if he will eat, he will not have pain, but after 1.5 hours or so, he will start having pain. And because he is not able to differentiate why that pain is there, he will keep snacking, he will keep eating more and more. Okay, and so a gastric ulcer patients typically will show a lot of loss of weight and something like that, and duodenal ulcer patient may gain weight because of excess snacking. So let's look at quickly the differences. So gastric ulcer, the blood group, typically it is seen in type A, whereas duodenal ulcers, most common people are affected belong to blood group B. Type 1 or lesser curvature is the common site for gastric ulcer. But here it happens in duodenal ulcer. It is primarily in the duodenal cavity. Remember, any multiple ulcers or ulcer beyond the second part of the duodenum, then you will have to think of Zollinger-Ellison syndrome. Okay, it will not be a peptic ulcer disease. Okay, pain is generally epigastric and immediately after the food, so weight loss, because the patient, the moment he eats it, then he will have pain, so he will start eating less and less. But here in duodenal ulcer, the epigastric pain is typically presenting as a hunger pain, because patient experiences the pain 2 hours after the food, so he will snack a lot and this may lead to weight gain. What is the investigation of choice for peptic ulcer, either gastric or duodenal? Is basically you do upper GI endoscopy and you can do a biopsy to look for H. pylori. How do we manage it now? Typically, ulcer production is there, so you use PPIs. PPIs are very effective. The ulcer healing time, remember, is 4 to 6 weeks, so we use PPIs almost for 6 weeks to manage these patients. Remember, if there is a refractory case, or which is like if you have given a 6 week treatment but still it is not responding, or the ulcers are reoccurring, or there are multiple ulcers, ulcers beyond the second part of the duodenum, so all these should prompt you to think in terms of Zollinger-Ellison syndrome. And a very characteristic difference between a simple peptic ulcer disease and a Zollinger-Ellison syndrome is Zollinger-Ellison syndrome will have secretory diarrhea. Because of the increased gastrin production, they will have secretory diarrhea. Again, in a very nutshell, I'll tell you the difference between secretory and osmotic. In osmotic diarrhea, if the patient stops eating, he will not have diarrhea. But in secretory diarrhea, even if the patient does not eat anything, he will have diarrhea. So remember this, I've already taken a class where I've completely differentiated between secretory as well as osmotic and how to investigate them. But remember, Zollinger-Ellison syndrome presents with secretory diarrhea. Okay, so this is the important differences between the two different types of ulcer. Let's look at how do we manage it. So because it's related to infection, type B gastritis is related to infection, so we will have to use antibiotics. And there are two regimes, one is triple therapy, one is quadruple therapy. In both we use two antibiotics. So here in triple therapy, we are using clarithromycin, amoxicillin along with clavulanic acid, okay? And then we use a PPI. When we talk about quadruple therapy, again, we are using two antibiotics, tetracycline and metronidazole along with a PPI. But here we are using a surface protecting agent, bismuth. So bismuth acts by reducing the acid mucosal contact time. So again, this is used in quadruple therapy. The question which was asked are which are the antibiotics which are not effective in treatment of type B gastritis or H. pylori infection, and the correct answer in the exam was erythromycin or azithromycin. Okay, so both these are not effective in treatment of H. pylori. So clarithromycin, amoxicillin, clavulanic acid you can give, or tetracycline along with metronidazole. So having understood the management, let's look at the quickly look at the complications which we will see in gastric ulcer. So remember, as a rule, bleeding, whenever there is a bleeding, you should know the source of the bleeding. So gastric ulcer can bleed also, and the source of bleeding in a gastric ulcer will be left gastric artery. Okay, and obviously it can perforate, but remember, all the gastric ulcers, if they perforate, they will perforate into the lesser sac. Whereas when we talk about duodenal ulcer, if they perforate, they will primarily perforate into the greater sac. Okay, you can also have hourglass stomach because of the you know formation of formation of the stricture. There can be an hourglass stomach typically seen in some of the gastric ulcer, at least old cases. And how do we manage it? Basically, you can do an upper GI endoscopy along with cautery. If that fails, you have to start with massive transfusion protocol because there is a bleeding artery. And if even that fails, then you have to go for an exploratory laparotomy along with ligation of the bleeder. So this is the two. Then we can have something called as penetration. So how penetration is different from perforation? Perforation is more acute, penetration is slow, eroding of the lining. And here what happens, because this gastric ulcer can erode into the pancreas and all, so you can have pseudo pancreatic cyst, as can be seen, or necrotizing pancreatitis. So again, penetration can be a complication, and obviously I told you all gastric ulcers are pre-malignant, so malignancy again is a complication of gastric ulcer. Let's look at how the duodenal ulcers will complicate. So again, duodenal ulcers perforate more common. When we looked at gastric ulcers, their main complication was bleeding, but duodenal ulcers primarily perforate, and in even anterior duodenal ulcers have more chances of perforation as compared to posterior. When we talk about which is more common, remember posterior is more common, but perforation primarily happens in the interior. So if you have a perforation, what are the various signs which can be seen? So there are some images which I would like to show. First is very easy, gas under the diaphragm. So you can see these are the diaphragm, and you can see the gas under the diaphragm. You can also have a mustache sign. Again, it is a representation of gas under the diaphragm. So you can see like a mustache sign. Another sign is cupola sign. So here what happens? Again, there is a continuous gas under the diaphragm, so you can see a continuous line. So this is called as cupola sign. And the last is pseudomediastinum. So here you can see the heart shadow, there is air above the heart shadow, so this is pseudomediastinum. So again, all of these can be asked as an image based question. Obviously perforation is there, even bleed, duodenal ulcers, even though gastric ulcers bleed more often, but duodenal ulcers can also bleed. And remember, when it comes to bleeding, posterior is more common than anterior. Okay, and what is the source? Here the gastroduodenal artery is the source. And how do we manage it? Primarily by giving adrenaline at the base of the ulcer. If it fails, then we can go for cautery ligation or exploratory laparotomy. So these are the important management. So this was a short topic, but again very important, and multiple MCQs have come from this. Thank you so much for watching this session, and hope you are enjoying these sessions.